let's say you have a patient who is older, in their 80s, a bit fragile, but they were able to get through chemo and concurrent radiation, weekly carboplatin paclitaxel. They've recovered okay. Do you have any hesitation about offering Imfinzi, Durvalumab immunotherapy to patients who are older and somewhat frail, but were able to get through chemo immunotherapy up to that point and don't have a signal that they should not get this?
No, I mean, I generally don't have a hesitation there. I mean, again, kind of if the patient's willing to come in every 2 weeks for their infusion and want to, be aggressive and feel that they, are recovered, fully recovered after the chemo radiation, I wouldn't have an issue with giving it.
Chemoradiation is one of the toughest things we do in lung cancer clinics. So if you get through that in good shape, honestly, the year of Durvalumab is probably significantly less toxic.
Yeah.
With exceptions, but on the whole, if you get through that, that's a pretty darn good credential.
Let's take the setting of a patient who is started on Durvalumab, doing okay, but the novelty begins to wear off at 7 or 8 months. And I feel that year is a challenge of attrition. Even if you don't have a prohibitive issue, every 2-week treatment, if they start to have concerns about this, I mean, we're in the Bay Area, people may have long drives to get in. Do you feel that it would be acceptable to change the schedule to do like a month, every 4 week, now that there's some data for this? Or do you feel that it's most appropriate to just hew to the schedule, or maybe even stop early just because we don't know how long we should do this and that there's nothing magical about a year? So how do you feel when a patient says, it's been 8 months, do I really have to come in every 2 weeks at this point?
Wow. Again, it's just a data-free zone. And I think it's a conversation. Like you say, there's no magic to the year. If we've gotten through 8 or 9 months and the patient feels very strongly, just quality of life wise, I tend to think there's probably good likelihood they've gotten the benefit they're going to get. I haven't done the 4-week scheduling, but there's so much precedent now in the stage 4 setting of, for example, Opdivo and Nivolumab, the 4-week really similar to 2-week benefit. I don't think it's a big stretch. It hasn't come up. My patients are pretty motivated, but I wouldn't have a major a priori problem with it, especially at month 8.
Yeah, and I think also we just don't have data, so who's to say? Millie, what's your thought?
I mean, I think in my VA practice, if there was an FDA label for the 4-week, I would absolutely go over to that. But we don't have that, and so I can't do that. I'm not sure if private insurers would actually cover the
Right.
4-week. So just from the logistical standpoint, I'm not sure that'll work. I typically see these patients once a month, and they're getting their one of their infusions sort of on their own, and they're going to the infusion center without seeing me. So it kind of shortens their, visit. And so it's a little bit more tolerable for them to be going through. And I too, if they've gotten through 8 months, they're kind of tired of it, I don't push them to make it to a year.
Let's take the situation of a patient who has gotten through a year of Durvalumab after chemo and radiation, and they are nervous. They are grateful that they don't have evidence of relapse recurrence on their last scan, but they are really fearful of stopping. And the Pacific trial, upon which our treatment is based, gave up to a year but stopped at a year. If you have a patient who is a year in and says, I don't mind coming in, I really feel better on treatment, this is probably more likely at the Stanford practice than at the VA, but maybe at UCSF, and certainly some of the tertiary care centers will have more patients who are seeking more care than we know is beneficial. What's your view there? Would you strongly dissuade patients from this, or are you open to that? I mean, presuming that you didn't have the barrier of coverage, which I think is an easy out.
I would really strongly urge them to stop. Again, it's not a stage 4 setting. It's a curative setting, and cure is binary. It just takes us 5 years or so to figure out if it happened. I would actually push them pretty strongly to say, we've got to hew to this trial. There's rationale to say that a year is sufficient. There's not data for longer in this setting, and really strongly urge them. And I also remind them that even if the first year went well, there are, unlike chemo, which tends to kind of accrue more side effects as you get deeper in. Cycle 6 is always harder than cycle 1. Immunotherapy side effects can happen on day 1. They can happen on day 720 too. And so you really, that
It's
more
a little
time,
idiosyncratic.
very
Yeah.
idiosyncratic.
Yeah.
So I kind of remind them of that and say, I've had enough patients in my practice where if I'm giving a drug that I'm not sure is helping, but I can sure affect your thyroid, I can sure affect, like I said, my patient with a pancreas, with new autoimmune diabetes.
Yeah.
These are things that affect quality of life also. So I would push pretty strongly to stop that.
And obviously the VA is going to just double over laughing. at the
Exactly.
Yeah, right.
But-
Nice try.
You want to do what?
Right.
But I mean, if you were covering at Stanford, at the Cancer Center at Stanford that day, you had a patient, what would your guidance be if you weren't limited by payer concerns?
Yeah, I think my sentiments align with Matt's. I mean, I don't think we have data to really support using it, beyond a year. And I do worry about the potential for autoimmune toxicities. And again, they may have been lucky in not having developed them in that year, but I just don't want to really take that risk, especially when we really don't know that it's helping. So
I would also say that this is a setting where I think we do have some information now as the data mature from Pacific, where we see the survival curves at 2 and 3 years are not converging in a way that would suggest that this is just a temporary benefit, and as soon as you stop the therapy, the benefit is gone. There's real hope, I think almost an expectation, that the benefit from that year is sustained, whether that killed the last cancer cell or it has trained the immune system to now sustainably treat the microscopic amount of cancer that exists. But the fact that the curves are just as separate at 3 years as at 18 months would lead me to be pretty strong in my recommendation against ongoing indefinite treatment for the reasons you mentioned, and the fact that in stage 4 disease, we do have patients who are years out who are still enjoying the benefit of no progression, even potentially long after they've discontinued a drug like Keytruda or one of these other immunotherapies.